1, 2,
And
Patient's here.
female.
Oh shit, almost got some blood going. Oh, he's wearing it too.
You're in the bay. Once you get over to the bed, we'll give you the story. Everything's going to happen super fast. Welcome to the emergency room.
I lost the phone.
It's charter book.
300 please.
I'll keep you on again.
Pulse check. No pulse.
No more pulse.
Yeah. Here, what do the echo people say? And her blood pressure is off the dropping.
45 minutes of CPR and no return of circulation. Okay.
Imagine walking into a room, right? And you have to basically decode a total stranger's deepest trauma, their mental capacity, maybe even their potential for physical violence. And you have to do all of this in like a 10-minute conversation.
Yeah, it's an incredibly intense situation.
Right, because you don't have an MRI machine. You don't have like a blood test that just spits out a psychiatric diagnosis.
Right.
And the person sitting across from you might be actively trying to hide their symptoms.
Which happens a lot more often than people think.
So welcome to the deep dive, because today, for you listening, we are exploring the really fascinating high-stakes art of the psychosocial assessment.
It truly is a high-stakes environment. I mean, you're leaving the realm of simple binary medical data and entering the space where human behavior, emotion, and perception are basically your primary vital signs.
It's just wild to think about.
It is. It's an incredibly complex skill set to master.
And our mission today is to figure out exactly how mental health professionals pull this off. Like, how do they act as part detective, part confidant, and part crisis negotiator to decode a patient's internal world?
Right.
Because, I mean, let's be real, this is not just a friendly chat, even if a really skilled practitioner makes it look like one.
Exactly. It's so much more than that. And if we connect this to the bigger picture, it's crucial to understand that the primary goal of this interaction is establishing a clinical baseline to find immediate cues for action.
Cues for action, meaning?
Meaning the practitioner is scanning for data that requires urgent intervention. So like a risk of self-harm or severe cognitive decline. Things that can't wait.
Got it.
Furthermore, without that rigorous initial baseline, there's absolutely no way to evaluate whether a treatment plan is working, say, 3 weeks or 3 months down the line. You know, you have to know exactly what the baseline is to measure any progress.
Okay, let's unpack this. Because before we can even talk about the specific questions a nurse or clinician asks, we really have to talk about the hidden barriers in the room.
Oh, the invisible filters.
Yes, exactly. These invisible filters that can completely skew the answers they get. Because it's incredibly dangerous to treat a psychiatric assessment as just a straightforward, objective Q&A, right?
It's a hugely common pitfall. I mean, a thorough psychosocial assessment requires active, honest participation from the client. But there are immense, often invisible factors that interfere with that.
Right.
And it all starts with the client's immediate physical and, well, physiological state.
Yeah, the physical state. I always think of this like trying to read a dense, complicated novel while a strobe light is flashing directly in your eyes.
That's a great way to put it.
Because if you ask a patient to deeply reflect on their emotional state while they're in acute physical pain, or, you know, if they're severely sleep deprived, or in the middle of a panic attack, the data you get back isn't their baseline mental state.
Not at all.
You're just measuring their pain or their exhaustion. The strobe light is basically blinding the entire process.
That is a highly accurate analogy. The strobe light of pain or severe anxiety completely monopolizes the brain's processing power. The clinician has to recognize that physiological hijacking immediately.
And they have to address it before they keep going. Right.
Exactly. They might need to halt the assessment entirely, allow the patient to rest, administer medication, or just wait for an acute panic response to subside.
Wow, so you literally just hit pause.
You have to. If you try to push through that physiological noise, the data you collect is fundamentally compromised. It's useless.
And it goes beyond just acute physical pain, too. I mean, the psychiatric condition itself can act as a massive barrier to gathering information.
Oh, absolutely. The very illness you're trying to assess often actively prevents the assessment.
Give me an example of that.
Well, for instance, if a patient is experiencing severe unmedicated depression, we often see what's called psychomotor retardation.
Meaning they're physically slowed down.
Exactly. They physically and mentally lack the energy to process a question, formulate an answer, and then speak it aloud. It's not defiance, It's an actual inability to participate.
That's so sad, but it makes total sense.
And on the flip side, if a client is exhibiting active psychotic thought processes, they're likely dealing with internal stimuli.
Like hallucinations.
Right, like auditory hallucinations. They might literally be hearing voices that are louder and more demanding than the clinician's questions.
So in those moments where the patient's condition literally prevents a standard interview, how does the clinician pivot? I mean, they can't just leave the chart blank, right?
No, they definitely can't. So they shift from active interviewing to passive observation and collateral data gathering.
Okay, what does that look like?
They analyze the patient's physical movements, their hygiene, their interactions with the air around them. They'll dive into past medical records, and they lean heavily on observations from friends, family, or first responders who brought the patient in.
I see.
So the assessment continues, it changes shape.
Which brings us to another massive invisible filter. The patient's past experiences and their fundamental level of trust. Because when someone walks into a clinical setting, they carry their entire history with the healthcare system right in there with them.
Yes, and in mental health care, trust is never a given. Honestly, mistrust is often the baseline.
Really?
The baseline. Yeah, especially if a patient has a history of trauma, particularly institutional trauma, or, unsatisfactory, dismissive experiences with healthcare providers. Their immediate instinct is self-protection.
Which obviously drastically alters the data.
Completely. They might minimize their symptoms, like downplaying severe distress, because their primary goal is just to escape the facility as fast as possible.
Right, just tell them what they want to hear so I can leave.
Exactly. Or, paradoxically, they might maximize their symptoms out of sheer frustration. They might exaggerate behaviors because they feel like they won't be taken seriously otherwise.
That makes total sense. If you've been ignored for years, you might feel like you have to scream just to be heard at a whisper. But here is the piece of the puzzle that I think often gets overlooked. The clinician brings their own filter to the room, too.
Oh, 100%.
Because we have this societal assumption that healthcare providers are these, perfectly neutral, objective measuring tools. But the clinician's attitude, their micro-expressions, their comfort level, that plays a massive role in what the patient actually reveals.
Human beings are exceptionally attuned to social cues and threats. If a patient perceives the clinician as rushed, dismissive, or just, going through the motions of checking boxes on a digital tablet.
You're going to pick up on that immediately.
Exactly. The patient will mirror that energy. They'll provide the most superficial, brief answers possible just to end the interaction.
It's the micro-expressions that really get me, though. Like if a patient is about to disclose something incredibly heavy, like a history of severe domestic violence or childhood abuse, they are hyper-vigilant.
You're watching everything you do.
Right. They are scanning the clinician's face. If the clinician stiffens up or breaks eye contact or seems even slightly uncomfortable with the topic, the patient instantly registers that discomfort and just shuts down.
They absolutely do.
They protect themselves, and honestly, they protect the clinician by just keeping the secret. So the clinician has to maintain this perfectly calibrated, matter-of-fact composure no matter what is being said.
That's spot on. The clinician's emotional discomfort instantly becomes a barrier to the patient's clinical truth, which, leads us logically to the next phase of the assessment, the physical architecture of trust.
Right, because if both the patient and the clinician are bringing all these complex, invisible filters to the table, the environment where this conversation happens has to be deliberately constructed to mitigate that tension.
It's all about setting the stage.
Exactly. So logically, if you're trying to get a hypervigilant patient to open up about their deepest traumas and, illicit behaviors, wouldn't you want absolute privacy?
You'd think so.
Shouldn't you take them to an isolated, soundproof room at the very end of a dead-end hallway where they know for a fact nobody can overhear them?
From a layman's perspective, yes. But from a clinical security standpoint, that is incredibly dangerous.
Really?
Yeah, total isolation is actually a severe hazard. I mean, you absolutely need a quiet space to ensure confidentiality, like a standard consultation room near the main floor. Because if a patient thinks the person in the waiting room can hear them, they won't say a word.
Sure, obviously.
But you must never choose an isolated remote location, particularly if the client's history is unknown or if they have any prior record of agitation or threatening behavior.
So it is this constant tightrope walk between emotional confidentiality and physical security. You need privacy, but you also need proximity to help.
Precisely. The safety of the clinician and the patient is always the ultimate priority.
So what do you do if they might be aggressive?
If there's a known risk of sudden aggression, the environment has to be modified. That might mean keeping the door slightly ajar, positioning the clinician closer to the exit, or even having a second staff member present in the room during the interview.
Which, of course, introduces a whole new variable to the social environment.
It complicates things for sure.
And speaking of other people in the room, navigating the family dynamic seems like an absolute minefield, like it's a total double-edged sword.
It is arguably one of the most delicate negotiations in an assessment. Having a family member or caregiver present can provide incredibly rich collateral data, especially if the patient's cognitive function is impaired.
But the interpersonal dynamics often skew the primary interview, right?
Constantly.
Right,
Yeah.
because you might have a severely anxious patient who flat out refuses to speak unless their spouse is sitting right next to them holding their hand.
Yes, that happens frequently.
But the moment that spouse is in the room, the spouse might start answering for the patient, or they might hold back crucial context because they don't want to agitate the patient.
Or, far more dangerously, the patient withholds the truth because of the person sitting next to them.
Oh, wow. Yeah.
This brings up an absolute non-negotiable rule in these assessments. In any situation where there is even a faint suspicion of abuse, domestic violence, or intimidation, the clinician must find a way to interview the patient alone.
But how do you even do that without tipping off the abuser and putting the patient in more danger?
You rely on standard operating procedures as your cover.
Oh, that's smart.
Yeah, a skilled clinician will say something like, hospital policy requires me to complete this specific form with the patient privately. I'll just need 5 minutes.
So you take the blame off the patient and place it entirely on the institution.
Exactly, because you cannot accurately assess a victim of abuse if the person perpetrating that abuse is sitting 2 feet away, monitoring every single syllable they speak.
That is such a vital protocol. Okay, so we've navigated the invisible psychological filters.
Yeah.
We've constructed a safe, secure, non-isolated physical environment.
Now the actual conversation begins.
Right. And what stands out so clearly here is that how the question is delivered is just as critical as the clinical content of the question. It's the art of the ask.
The linguistic phrasing dictates the quality of the data, and a seasoned clinician is constantly modulating between open-ended and closed-ended inquiries, depending on the cognitive state of the patient in that exact second.
Since anyone listening to this understands the basic difference between an open question and a closed question, let's talk about the strategy of when to pivot. Because you generally want to start open, right? Give them the floor to see where their mind naturally goes.
That's the ideal starting point, yes.
But if their psychiatric condition makes their thinking disorganized, you have to tighten the reins.
Precisely. If you ask an open question and the patient becomes flooded, unable to sequence their thoughts, or they start speaking in, word salad.
The open question has basically failed as a tool.
Exactly. You must immediately pivot to direct, focused inquiries to ground them and reduce their cognitive load.
Which brings up one of my favorite concepts here regarding cognitive load. The danger of the multi-part question.
Yes, this is huge.
I like to think of this as throwing 3 tennis balls at a patient at the exact same time. If you ask, have you been experiencing any changes in your appetite, your sleep patterns, or your energy levels? You are completely overloading their processing ability.
The brain just jams.
Exactly. They might catch the last ball, tell you about their energy, and completely forget to mention they haven't eaten a solid meal in 4 days. You have to throw 1 ball at a time.
What's fascinating here is how this linguistic precision applies to highly sensitive, stigmatized topics, too. It isn't just about managing cognitive load. It's about entirely stripping the clinician's language of any inherent moral judgment.
Yes. The psychological mechanism behind this is brilliant. If you want the truth about a stigmatized behavior, you cannot back the patient into a moral corner.
Consider how a clinician asks about parenting practices, particularly if they're screening for potential abuse. If the clinician asks, how often do you physically punish your child? That phrasing carries a heavy moral weight.
It totally does. It implies the clinician believes physical punishment is occurring and that it is inherently wrong.
Right. And the patient's psychological defenses activate instantly. They feel judged, they feel cornered, and they will likely lie to protect their family unit.
But if you just shift the language slightly to, what types of discipline do you use in your home? It changes the entire reality of the conversation.
Exactly. It operates on an assumption of neutrality. It treats discipline as a standard variable of parenting, not an accusation.
And because it doesn't trigger that immediate defensiveness, it yields raw, honest data.
Right. The patient might openly admit to using physical force because the clinician's tone made it feel safe to disclose.
It's amazing how changing 3 words can bypass a person's entire psychological defense system.
That really is an art form.
So we've stripped away the judgment, and now the patient's actually giving us raw data. Here's where it gets really interesting. How does the clinician organize all this data?
Because you can't just write down random quotes on a notepad.
Right, you have to build a clinical picture. This brings us to the core framework, the 9-part mental X-ray. Let's weave through these categories because they reveal so much about how a psychiatric professional sees the world.
Without an organizing framework, you just have noise. This structure ensures a systematic approach, filtering the data into actionable categories.
Let's start with the foundation. The patient's history. This isn't just their age and cultural background, right? Family history plays a massive role here.
It does.
Why is knowing that a patient's father had bipolar disorder or a history of alcohol abuse so critical in that first 10 minutes?
Because psychiatric conditions heavily involve genetic loading and environmental modeling. A family history of bipolar disorder, schizophrenia, or completed suicide drastically increases the statistical risk for the patient.
So it's a huge red flag to watch out for.
It is. It also tells you about the environment they were raised in. Behaviors that seem wildly pathological to the clinician might have been completely normalized in the patient's childhood home. It provides a lens through which to view their current distress.
Okay, next is general appearance and motor behavior. This is the visual sweep. And they aren't just judging fashion choices, obviously.
No, not at all.
They're looking at hygiene, posture, and the appropriateness of dress. Like, if a patient walks in wearing a heavy winter parka in the middle of July, that isn't just a quirk, right? That's a serious data point.
Exactly. It indicates a breakdown in executive function or a disconnect from physical reality. Appearance is the outward manifestation of internal organization.
Wow, that's a profound way to look at it.
Someone who has stopped bathing or brushing their hair isn't just letting themselves go, they are demonstrating a severe decline in their functional baseline.
Then we get to mood and effect.
Yeah.
And I really want to spend a second here because colloquially, people use these words to mean the exact same thing.
They do, but clinically they are distinct, and the space between them is where the real diagnostic clues live.
Break that down for us.
The distinction is vital. Mood is the patient's pervasive internal emotional climate. It is what they explicitly tell you they are feeling.
Okay.
Affect is the outward expression of that emotion, the weather. It's their facial expressions, their vocal tone, their hand gestures.
So the clinician is constantly checking to see if the climate matches the weather.
Precisely. We are looking for congruence. If a patient states their mood is entirely devoid of hope and they feel utterly devastated, but their affect is bright, they are smiling and they're laughing at jokes.
That incongruence is a major red flag.
Huge red flag. It suggests profound dissociation, a psychotic process, or extreme masking.
Okay, next up is thought process and content. Again, 2 things that sound totally identical to a layperson, but the difference is essentially the cargo versus the train, right?
That is an excellent analogy. The content is the cargo. What exactly is the client thinking about? Are they fixated on a specific delusion? Do they have intrusive thoughts of self-harm?
Now the process.
The process is the train tracks. How are they thinking? Is their logic linear and goal-directed? Or are their thoughts derailed, jumping rapidly from one totally unrelated topic to another?
Oh, I see.
You can have a patient with perfectly benign, normal thought content, but a highly disorganized thought process.
Then we have sensorium and intellectual processes. This is where we measure if the patient is anchored in the same physical reality as the clinician. Orientation to time and place, memory, concentration.
Right.
But how do you actually test this without sounding like a robot? You can't just suddenly say, who is the president and what year is it, in the middle of a delicate conversation.
A skilled clinician embeds these tests seamlessly into the natural flow of the history taking.
Give me an example.
Instead of a pop quiz, you ask them to detail the chronological timeline of their symptoms over the last week. That naturally tests their recent memory, their concentration, and their orientation to time, all while gathering historical data.
That's incredibly smooth.
Of course, you are also assessing for hallucinations here, whether they are experiencing sensory inputs that simply do not exist in the room.
Which flows right into judgment and insight.
Yep.
So let's make sure we have this great. Is judgment essentially knowing that the stove is hot? But insight is understanding why you keep putting your hand on it.
That captures the essence beautifully. Judgment is the ability to accurately interpret the external environment and make safe, logical decisions based on that interpretation.
Right.
Insight is the patient's internal understanding of their own condition and their role in their circumstances.
So you could have a patient experiencing a severe manic episode who has terrible judgment, like they just drain their life savings to buy a boat they don't know how to sail, but they might actually have good insight knowing they're in the middle of a manic episode and need help.
Exactly. Or, conversely, a patient with chronic schizophrenia might have excellent judgment. They pay their bills, they navigate the bus system safely, but they have zero insight, firmly believing they have no psychiatric illness whatsoever.
And measuring these two capacities separately dictates the entire treatment approach.
It dictates everything, really.
The final three categories really interweave with each other: self-concept, roles and relationships, and physiological self-care. Basically, how you view your own worth directly impacts how you function as a parent or an employee, which in turn impacts whether you bother to eat, sleep, or take your medication.
They are deeply interconnected feedback loops. And looking at this entire 9-part framework, this raises an important question about how we synthesize all this data.
Right, because you can't just measure a patient's data against a universal static norm.
You can't. You have to evaluate it for developmental congruence.
Meaning measuring their presentation against what is expected for their specific stage in life.
Correct. The clinician is constantly comparing the patient's chronological age with their psychosocial presentation.
How does that look in practice?
Well, if a patient is exhibiting intense rebellion against authority figures and struggling deeply with questions of personal identity, that is developmentally congruent and perfectly healthy for a 16-year-old.
Sure.
But if you see that exact same intense behavioral profile in a 45-year-old, it's clinically significant. It highlights an area where development may have been arrested by trauma or illness, and it directs the therapeutic focus.
Wow. So what does this all mean? When you step back and look at the sheer scale of this process, navigating the physiological strobe lights, bypassing the psychological defenses, carefully constructing an environment of safety, stripping your language of moral judgment, and simultaneously running a 9-part mental X-ray, it becomes incredibly clear that a psychosocial assessment is an absolute masterclass in human communication.
It really is.
It isn't a form on a clipboard. It is a highly sensitive, dynamic dance designed to cut through fear to find clinical truth.
It is a remarkable, often exhausting skill. Clinicians are architecting trust in real time, frequently with people who are experiencing the worst, most terrifying day of their lives.
Yeah, that's heavy.
And as we rely more and more on technology and healthcare, it presents a fascinating dilemma for you to think about. We're seeing a massive push toward telehealth, digital mental health screenings, and even AI-driven assessment chatbots.
Which is everywhere now.
But we've just spent this entire deep dive discussing how a patient's truth is intimately tied to the microscopic human elements of a room, the clinician's eye contact, the slight softening of their vocal tone, the physical proximity of safety.
The micro expressions we talked about earlier.
Exactly. So you really have to wonder, can an algorithm ever truly sense the tension in a room? Can an AI register the incongruence between a patient's desperate eyes and their forced smile? Or, as we modernize, are we going to lose the invisible, deeply human cues that make this assessment actually work?
That is a brilliant point to end on. How much of our safety relies on the simple fact that the person sitting across from us is actually a person? Thanks for joining us on this deep dive.